Welcome to Info Medical Cards, your trusted source for quick, high-yield medical reviews. This session is about the topic syncope. Don't forget to like, share, and subscribe. Syncope, a sudden collapse that catches everyone off guard. In this presentation, we uncover what it is, why it happens, and what to do when it strikes. By definition, syncope, or commonly the term fainting, refers to a sudden loss of consciousness and loss of muscle strength, which is usually a temporary state and mostly spontaneously recovered. Let's understand the core mechanism behind syncope, also known as fainting. The medical term is transient global cerebral hypoperfusion, a temporary drop in blood flow to the entire brain. To make this concept easy to remember, we use two mnemonics, fainting and drop flow. Let's summarize the key clinical and physiological features. During syncope, there is a sudden drop in blood flow to the brain. Syncope starts suddenly. There's usually no warning or only brief symptoms like dizziness. Unlike a stroke, which affects one part of the brain, syncope affects the entire brain at once. Patients often report signs like blurred vision, nausea, or lightheadedness just before collapsing. The person loses consciousness only briefly, usually less than a minute. Most people wake up quickly and fully, often within seconds or minutes, without confusion. No focal deficits, that's key. There are no lingering signs like weakness or slurred speech. If there are, think stroke, not syncope. The brain needs a constant supply of glucose and oxygen. Without them, even for a few seconds, syncope occurs. Because the entire brain is affected, prompt recognition and prevention are crucial, especially in patients with heart or neurological issues. So always try to remember the two mnemonics. Syncope is a clinical symptom and it's not a diagnosis. The key objective is to distinguish between its various types based on their underlying pathophysiology. Syncope, or fainting, can have many different causes. Understanding the type of syncope helps guide diagnosis and treatment. Let's explore the four major categories, along with some additional causes. First, vascular syncope. This is the most common category and includes causes related to abnormal blood pressure regulation. Examples include orthostatic dysregulation, where blood pressure drops upon standing, vasovagal episodes, often triggered by stress or pain, hypotension, and carotid sinus syndrome. It can also include post-pressor states and transient ischemic attacks, also known as mini-strokes. Next, cardiac syncope, often the most dangerous. It arises from heart rhythm disturbances or structural heart disease. This includes supraventricular and ventricular arrhythmias, myocardial infarction, aortic stenosis, hypertrophic cardiomyopathy, and long-court syndrome, all of which can reduce blood flow to the brain suddenly. Cerebral syncope is related to primary brain events. Though not always classified as true syncope, conditions like seizures, basilar artery migraines, or cerebrovascular disease can mimic or cause brief loss of consciousness. Psychogenic syncope refers to fainting that results from psychological causes, such as anxiety disorders, somatization, or non-epileptic seizures. These are often seen in younger individuals and may require mental health evaluation. Finally, there are other causes that don't fit neatly into the main categories. These include drug or medication effects, dehydration, pulmonary embolism, hyperventilation, and epileptic events. Each of these can temporarily impair blood flow or brain function, leading to collapse. There are two simple valuable tests to assess the autonomic circulatory regulation important. Shelong test. It's a simple and valuable tool used to assess autonomic circulatory regulation in patients with suspected orthostatic hypotension or postural syndromes. The test begins with the patient lying in a supine position for 5 to 10 minutes. During this time, baseline blood pressure and heart rate are recorded. Next, the patient is asked to stand up quickly and remains in the upright position for up to 10 minutes. During this period, blood pressure and heart rate are measured at regular intervals, typically after 1, 3, 5, and 10 minutes. A systolic blood pressure drop of 20 mm of mercury or more, or a diastolic drop of at least 10 mm, is indicative of orthostatic hypotension. If the pulse increases by more than 30 beats per minute without a blood pressure drop, POTS, postural orthostatic tachycardia syndrome, may be suspected. If there is no significant change, the result is considered normal. Tilt table test. It's a valuable diagnostic tool used to investigate the causes of unexplained fainting or syncope. The tilt table test helps assess how the autonomic nervous system controls blood pressure and heart rate when the body changes position from lying down to standing. The procedure begins with the patient lying flat on a motorized table. After resting for 10 to 20 minutes, baseline heart rate and blood pressure are recorded. Next, the table is slowly tilted to an angle of 60 to 80 degrees, simulating an upright position. The patient remains in this position for up to 45 minutes, while vital signs and symptoms are closely monitored. In some cases, medications such as nitroglycerin or isoproterenol are administered to provoke a response and enhance diagnostic accuracy. The test looks for signs of vasovagal syncope, orthostatic hypotension, or POTS, postural orthostatic tachycardia syndrome. A drop in blood pressure and heart rate accompanied by symptoms such as dizziness or fainting suggests vasovagal syncope. A significant drop in blood pressure without a corresponding heart rate change may indicate orthostatic hypotension. If the heart rate rises sharply, by more than 30 beats per minute, without a drop in blood pressure, POTS may be diagnosed. The tilt table test is safe, non-invasive, and offers valuable insight into syncope, especially when episodes are recurrent or unexplained. The Shillong test is non-invasive, quick, and can help identify vascular causes of syncope, especially in elderly patients or those on antihypertensive medication. Always ensure the patient is closely observed during the test to prevent falls or complications. Now let's walk through the structured approach to diagnosing syncope, a transient loss of consciousness due to reduced cerebral blood flow. We begin with the most important step, history taking. Ask about the circumstances of the episode, any prodromal symptoms like dizziness or nausea, onset and duration, recovery, and relevant medical or family history. Identifying triggers such as pain, emotional stress, or exertion is also crucial. Next, conduct a thorough physical examination. Assess vital signs, especially orthostatic blood pressure. Perform a detailed cardiac and neurologic exam, and look for signs of volume depletion. Then move on to the ECG, checking for any bradyarrhythmias, tachyarrhythmias, conduction blocks, or signs of ischemia. An abnormal ECG may point directly to a cardiac cause. Following this, apply risk stratification. High-risk features include syncope during exertion or while lying down, absence of warning symptoms, and any abnormal exam findings. These patients may need urgent cardiac evaluation. In parallel, consider possible mimics of syncope, such as seizures, hypoglycemia, or psychogenic causes. These are not true syncopal episodes and often require a different workup. Finally, classify the syncope into one of three major categories: reflex syncope, like vasovagal or situational, orthostatic hypotension, often due to volume loss or autonomic failure, or cardiac syncope, linked to arrhythmias or structural heart disease. Let's take a closer look at two important medications, etalpharin and dihydroergotamine mesylate. First, etalpharin. This is a sympathomimetic agent, meaning it mimics the action of the body's own adrenaline. It primarily stimulates alpha and beta-1 adrenergic receptors, leading to vasoconstriction and increased cardiac output. The result? A rise in blood pressure. That's why etalpharin is commonly used to treat orthostatic hypotension. Now, dihydroergotamine mesylate, often referred to simply as DHE. This is a derivative of ergot alkaloids and is best known for its role in treating migraines and cluster headaches. It works by constricting dilated cranial blood vessels and targeting serotonin receptors, particularly 5-HT1B and 5-HT1D. This helps stop migraine attacks in their tracks. Although it has some vasoconstrictive effects, its use in managing hypotension is now rare. A systematic clinical approach can often reveal the cause of syncope without the need for specialized testing. Recognizing the type of syncope is critical, because while many cases are benign, others can signal serious underlying conditions requiring urgent care. Timely recognition, risk assessment, and targeted treatment can make all the difference, especially when syncope is a warning sign of something more serious. So stay tuned, like, share, and subscribe to www.youtube.com/@infomedicalcards for more quick emergency reviews.